Awesome. Okay. Animations, no. Slideshow, yes. All right. Play from start. Okay. All right. I'm going to ask the standard question. Can you all see my screen, or enough of you see it? Okay. Awesome. Okay. My caveat, my main caveat for this is I spent a fair amount of time looking for really good new papers to say, like, this is the state of the art for cartilage injuries. And we do not have awesome cartilage data that has come out in the last 5 years. So normally when I try to do these talks, I try to find like what's the best, most recent data. And the reality is I think a lot of the cartilage data that came out from the 2000s was some of the best data. So I'll try to highlight more recent studies where I can. Let me figure out how to make these things go forward. So really basically, I had to throw this in, understanding cartilage for patients. And for you guys, um, if you remember back to your basic science talks, and we will record a better cartilage basic science talk for you to watch at your leisure. Remember that there's multiple layers of cartilage. There's the tangential layer, which has very few cells. You have the transitional layer, which has chondrocytes that are that form a lot of cartilage. You have the calcified cartilage layer, which is important in microfracture. This is the area that we don't want to disrupt. And then you have bone. Okay. Um, Importantly, just for any med students or people who have forgotten everything about histology, remember that cartilage has few cells and no nerve endings. That means that it's really, really, really smooth and you don't feel your joints moving. So that's the way I describe it to patients. Is the reason why you didn't know you had arthritis is you have to have pretty advanced arthritis before you notice it. And there's no early warning system. So it's kind of the opposite of skin, where you feel like you feel a hot stove when you get close to it. You have no sense that you're losing cartilage until it's essentially too late. How smooth is it? I say it's as smooth as Dr. Satoriano trying to teach high school students. If you wonder what happens if you Google Nick Satoriano, you get a picture of him suturing from San Ignatius High School and wearing a stethoscope for no particular reason. So that's how smooth cartilage is. Dr. Stroud is looking skeptical. I used to have a picture of David Hasselhoff here, but nobody knows who David Hasselhoff is anymore. The second closest I could find in terms of hairiness and smoothness was Nick. Okay. So you kind of heard from Drew in the setting of ACL injuries, what we do with healthy cartilage. We're going to talk about cartilage injuries in and of themselves today. And then you're going to listen to Dr. Wingfield talk about what we do for people with advanced arthritis. I would highly, highly encourage you to stay on the call for Dr. Wingfield or switch to her call because she is an expert in treating this. And by and large, no matter what specialty you go into, you're going to see a lot of these patients. One thing that I did want to bring up with this slide is we call early cartilage injuries early arthritis, but we don't necessarily have that data. There are people that probably develop isolated cartilage injuries and remain asymptomatic, and other patients develop isolated cartilage injuries that extend over time. And we can't necessarily at this point in time differentiate those patients. So for a history and physical exam for cartilage, I'll keep this relatively straightforward. The main sign that patients will have with a cartilage injury is swelling and pain. They're actually usually pretty okay for just walking around or doing exercise bike, but that higher level of activity, landing, especially for medial and lateral femoral condyle injuries that are usually in the central weight-bearing portion, they're not going to be able to load like on a jump and a pivot. Some patients will describe catching and locking. It's actually, there was a really good article that just came out in JBJS that said like our signs that we call meniscus signs of catching and locking are actually more common with cartilage pathology, which I think is interesting. What I look for on physical exam is an effusion. So an unexplained effusion without joint line tenderness and without a ligamentous instability is a cartilage injury until proven otherwise, unless it's ski season and then it's bone bruising from a near ACL injury. Especially with your skinnier patients, you can essentially palpate along the medial femoral condyles and look for tenderness. And then obviously check for meniscus signs and ligament instability. When we look at when we look for the diagnosis of cartilage injuries, we always get radiographs. We're looking for a few different things. We just want to rule out fracture or osteochondral fragments, and we want to overall look for joint space narrowing and get somewhat of a alignment view with our standard knee series. I think it's pretty much standard of practice here and should be standard of practice most places to get alignment films if you are considering a cartilage procedure of any sort. And for us, we get MRIs as the gold standard for evaluating cartilage injury. T1-Row gives you a qualitative evaluation of cartilage, which in some academic centers you can use. Okay, so this is just an example of somebody that comes in with increasing knee pain. Even on x-ray, you can see that he has something going on in the medial compartment. He's got some bony abnormalities in general, but you can see that something doesn't look quite right. And if you look really closely, you can see there's also probably a little loose body or something loose floating around inside the knee. When we look closer, we can see that there's definitely something that looks abnormal through this area. And this is what this guy's MRI looks like. You can see that cystic change through this area, an abnormal surface, and what looks like could be something that could be flipping back and forth in this area here. So get both images. So for cartilage, when I think about it, I try to think of a variety of different things. In general, I like to think that one of the most important things is not all cartilage lesions are symptomatic, especially in the patellofemoral joint. So oftentimes, just like with shoulder, you're going to get a, that's automatically advancing. Hold on one sec. Let's see. Questions so far? Will I figure out how to not play narrations, use timing? Okay, cool. All right. Questions so far? Hopefully not. Play from. Okay, so going back, now I know how much I was supposed to be talking based on my speed. So many patients are going to have cartilage injuries that you don't need to treat, okay? So if a patient is asymptomatic and has cartilage injuries or early cartilage loss, or what's often read as chondrosis, I often tell patients that's normal for age. That's like saying that I went to a dermatologist and got a hair count and pigmentation count for my head. It doesn't look the same as when I was 20. We're not going to discuss the non-operative options today. The most common non-operative option we talk about is rehab. I haven't seen a great study that showed that it works. The most important thing for early cartilage injuries and early arthritis, which Dr. Wingfield will hopefully teach you, is weight loss. So the most important thing you can do for patients who are overweight is lower the joint reactive forces, and that's usually by weight loss. That's probably why rehab works. Cartilage repair is something we talk about more with kids, so I'm going to defer that to Nirav. In general, if it's on the boards and you have an isolated cartilage injury with no bone on the back, it's not really going to heal very well. Any bone on the back in a kid, you should try fixation because it will usually work. Okay, and then we're going to go over all these. If you get to the point where you're doing partial joint replacements, send them to Dr. Ward so he can talk gently and delicately to your patients and tell them that they need a partial joint replacement. So I think there's a couple different ways to think about this. The most common way to think about these procedures is based on size. The bigger the lesion, the bigger the surgery that we're going to do. Usually for these small, and this should be centimeters squared, we're going to talk about doing microfracture. For 2 to 4 centimeters, we're going to talk about osteochondral autograft or mosaic plasty or MACI. And then for bigger lesions or more geographically diverse lesions, we're going to talk about osteochondral allograft or MACI. And then with global cartilage loss, knee replacement. Okay. So for treatment of all of these cartilage injuries, the surgical principle is you're going to use the appropriate cartilage technique for the appropriate size lesion. So kind of like what Dr. Lieberman used to say to us was the appropriate sized incision for the appropriate sized patient. So everybody wants a minimally invasive procedure. It may not work for everybody. I can tell you from experience that most patients, when they hear about the different cartilage surgeries, want an arthroscopic procedure. So it's really easy to lean towards microfracture to patients. Whether or not the data is actually very good, we'll kind of go over. You want to treat all the underlying conditions at the same time or have a plan to treat them in a staged way. So you're going to treat ligamentous instability at the same time, and you're going to consider realignment or osteotomy for offloading larger cartilage injuries or any joint axis malalignment. And in general, even though we're not going to cover osteotomies in today's talk, I want you to think about that as something that's going to be corrected so that your cartilage injury doesn't wear out after you've done the repair. If you remember nothing else, so you decide you've heard enough and it's time to go to work, the cartilage repair should be indicated for the right patient with a stable, meaning all your ligaments are intact, a well-aligned knee with the appropriate meniscus without any risk factors for early failure. The problem is, and I'm realizing that my most recent save didn't work because there should be a parentheses here, we don't have these risk factors for perfectly worn out, and we have different indications. So Charlie, since I'm making eye contact with you, what BMI would be your cutoff for a patient undergoing a generalized cartilage procedure?
Probably 30.
30. All right. Stephen?
Probably higher than that, 35 or 40.
Okay. All right. So Stephen, by definition, is nicer than Charlie. He is willing to treat patients more kindly. And it really depends on what study you look at. Yeah, I've seen both, but you figure a lot of prior athletes who have a high level or high rate of injury are in the BMI of 35 or 30 to 35. I would say if you're on your OITE, they're not going to give you somebody in the 32, 33 range. And both of those numbers have been thrown about. What about smoking? So Dr. Stroud, would you do a cartilage procedure on a smoker?
To be honest, I think it would depend on their age and their smoking volume. But obviously, smoking of any kind is going to increase the risk for failure.
Yeah. Yeah, and I think smoking is one of those things that we know works. It works negatively for everything that we do. I think if it's a additional factor that their BMI is 36, they are going to have to undergo an osteotomy as well, then it's probably reasonable to say, hey, we at least need you to decrease your smoking. But as an absolute contraindication, I think it's a hard sell. Okay. All right. So first one, Ryan Freshman, I see, oh, you're looking right at me. That's awesome. Okay, good. I'm glad you're paying attention. So this is a 25-year-old female. She has knee pain after soccer. She has some intermittent swelling and says she's got some catching and locking. She can't really do her cardio activities and she can't really get back to sports. I'm going to give you that her x-rays show some patellar tilt, but she isn't really complaining of any patellofemoral pain. And thankfully, she's a one medical person, so she comes in with this MRI. So without going into too much detail, tell me what you see on this MRI and what you're thinking about.
Sure. So she has what looks like a cartilage defect in the medial femoral condyle, kind of like the with some associated like underlying edema. It looks relatively small. And how old? She's 25 again. That's how old she is.
Yeah, she's 25.
25. Okay. Looks like the subchondral bone is still intact. And so my thought for her, given that she has locking, catching, and obviously we try to start off with PT, which I'm sure she has not done well with. But then, most likely that the things I would think about here is, given that it's small and she's unable to do non-op stuff, would be thinking about talking about a microfracture for her. That's my initial thoughts for this. I don't see anything wrong with her menisci. I don't see any other. I would also want to make sure she doesn't have other ligaments instability, and also
Okay.
alignment.
All right. So we have one vote for microfracture. Marcus, what do you think?
I was actually going to ask, would you even recommend starting with PT for this girl? And now that I'm saying this out loud, I almost waffle back. Like, you could try, my thoughts basically are benign neglect or microfracture, because once again, I agree with Ryan, this looks small. I can't tell actually, like, if this is hanging on by a thread, if it's going to start floating around in her joint at some point and that's causing issues. But I don't like you said, I think PT's benefit is for weight loss, and if her BMI is 25, like she doesn't need to lose weight. So I think I would counsel her that there's a chance that this piece floats around and things get worse, that you can do nothing and see if things get better, or I would favor to go in and yeah, I would think microfractured. Just given, I'm
Okay.
guessing this is less than 2 centimeters squared, but we obviously haven't measured it.
Yeah. Yeah, I mean, you can look at it. It's probably, I think I've got, let's see, I think it's 1.8 by 1.5. So not huge. It's probably honestly a little bit smaller. Dr. O'Donnell, any other thoughts? Would you lean towards benign neglect, osteochondral autograft, or microfracture?
I think I would lean towards microfracture for this patient. I think some of it could also be like you could discuss with the patient their goals, like 25. I don't know if they're like still actively an athlete, but I think that would contribute to my decision making.
Sure. So I think you all make really good points. And I think that's part of that's one of the challenges with cartilage surgery, is that there is not a perfect answer or a perfect algorithm. So things that I think about when I see this patient is, this is a small, well-contained lesion. So when I look at the cartilage here, there's a nice little cartilage side there, nice little cartilage side there. There is a flap. So I totally agree with Marcus. That flap may break off, but that's what's causing the problems. Based on that size, I would say this is what you would say as a small, well-contained lesion on the weight-bearing non-meniscal surface. So she's not going to be able to do well with think about with non-operative management. When she flexes to 20 degrees and tries to run, she's hitting right in the middle of this here. Now, this bone bruise is interesting because there is a study that Dr. Ma always quotes that nobody has ever found. So I think it must have shown up in an abstract. But they showed that people with bone marrow edema did worse with microfracture. And he will always bring that up. So anytime you're talking about microfracture in our sports conference, I would talk about it. But I would keep in mind that that hasn't really been shown, and it hasn't been reproducibly shown. Now, if you ask 100 sports surgeons, probably 90 of them are going to say this is the right indication for a microfracture. Okay. So for microfracture, what we do is we take a little awl and poke holes into the bone. Realistically, if they ask on the in-service, it allows, I stole this from an old OITE, but it allows for influx of mesenchymal cells into the defect area. They are going to differentiate into fibrocartilage and fill the defect. It is scar tissue. It isn't perfect cartilage. You form type 1, not type 2 collagen, and the biomechanics are not as strong with regular cartilage. What you're looking for in MRI or cartilage biopsy, which hopefully you're not doing too often, is a 75% fill, which makes it sense. Patients with a little bit of cartilage loss tend to do absolutely fine. The classic indications, which have not changed in a long period of time, are patients with less than a 2 centimeter squared lesion, which when you think about it is huge. Most of us are not really going to be doing a 2 centimeter square lesion. Grade 3 to 4 cartilage loss. So don't scrape off good cartilage to get to bad cartilage. All right. So your own native cartilage is always better than microfracture cartilage. So if it doesn't look perfect, it's okay. You want this to be on a weight-bearing area, obviously. Lower BMI, that hasn't been defined exactly well, and a non-kissing lesion. So you shouldn't be doing microfracture on the patella and trochlea, and you shouldn't be doing it on the tibia and femur. It's not going to work. Contraindications, most of these come from Kai Mithofer's study, but basically, too small, don't do anything to. Like if it's an incidental finding, the risk is that you poke holes in it and it forms bone, not cartilage. Diffuse disease. So this doesn't work as like a marrow stimulating. You're going to poke 30 holes in the knee and hope that cartilage regrows. And you might think, gosh, that's crazy. But I would say probably 2 or 3 times a year, I see a second opinion of somebody who's in their mid 50s, diffuse cartilage loss. They came in after a microfracture procedure at an outside institution. And they basically got a microfracture of every compartment and then full weight bearing. It doesn't work. Age greater than 40 is kind of controversial. Oftentimes when you talk to patients in their 40s, they don't want to believe that they're over 40, and you tell them you may not have enough stem cells to do this. They get really feisty. So you have to kind of tell them this may not work for you. I don't use age as an absolute cutoff, but I'm pretty rarely, like I'd say once every 2 or 3 years, doing a isolated microfracture in somebody over the age of 40. Lower, so this kind of falls into this lower demand, and we'll get into why, but people who are a little bit overweight still tend to do okay. If you're obese, it doesn't work, and if they're not going to follow the post-op regimen, you don't want to be doing it. So basically what you're going to do is you're going to debride down to the perfect rim. So you want a nice stable cartilage bed. You're going to poke holes around the outside because that's where it's going to grow the best. Your cells are essentially going to adhere both to cartilage and to bone here. So you work around the outside first and then through the middle. Your goal is to get these bleeding vents of bone and fat. And then what you want to see, what you don't want to do is break through in between these areas. As soon as you start breaking through and creating macrofractures, that's when you're going to form bone, not fibrocartilage. And then the protocol, which has never really been studied that well, but was in Dr. Stedman's initial paper on this, is non-weight bearing 6 weeks CPM for 6 hours a day. If you ask why, it's because we just do. Okay, so this most of the data that we cite comes from a long time ago. So this is now 15 years old, but this is Kai Mittenhofer's study. Looked at 48 patients at about 3.5 years after following surgery. A majority of the patient had good to excellent outcomes, fair in 25, and 4 out of these 48 had failed. Low BMI had better outcomes. MRI analysis showed that most of them had pretty good fill, 17% poor, and about 25% actually had some bony overgrowth. So those are ones that they probably didn't do a technically great procedure. They took down too much of the calcified cartilage, or they split through the bone. Fill, not surprisingly, was correlated with outcome. And this is this is probably the most extreme example. No fill, didn't do well. Fill, did fine. Okay. All right. Now, the main problem with microfracture is you have to tell patients that the outcomes deteriorate after about 7 years. And only about 65% will return to high-level impact sports. But the reality is that's the same for most cartilage procedures. Older patients don't do as well. There were a couple of studies done in the early 2000s that showed that stem cell concentration and colony forming units did somewhat depend on outcome. So if you didn't have if you had a very low number of colony forming units, you didn't do as well, which is not really surprising. And then this is kind of a nice meta-analysis that Chris Jones did that came out a couple years ago. They did a comparative effectiveness of cartilage repair. And what they found was that microfracture, the people did not achieve the MCID after about 5 to 7 years. So this kind of backs up what was seen many, many years ago, is that patients don't do as well 5 to 7 years later. Okay. All right, so that's microfracture. I do think there are the right patients for it. Certainly, like if you're doing an ACL procedure with meniscus repair and they have a cartilage injury, I think that's a great procedure. I think it's also pretty reasonable to consider for an isolated lesion in a well-aligned knee in somebody who is not super high demand. Okay, so this is the second patient. I'm just trying to make sure we stay on somewhat of time. This is a 17-year-old. He had a cartilage injury 3 years ago. He was already treated with microfracture. He had continued pain and swelling laterally with running and hiking. Can't really perform at the level that he wants to. He has normal x-rays, and he has this MRI, which he comes in, and because it's a PowerPoint conference, you only get 2 images to look at. So let's see, Fabian, are you available-ish? There you go. Awesome. All right. Do you see anything abnormal or a little bit weird on his imaging, and particularly this first one?
Yeah, I mean, he has some cartilage lesions on the posterior femoral condyle or posterior central femoral condyle on the
Okay.
lateral side.
How would you describe that lesion? Is it cartilage only, bone only,
It's both
cartilage
bone.
and bone?
Looks like osteochondral.
Yeah. Okay. So does microfracture fix a bone and cartilage injury?
No.
No. So you will see, and this is not that uncommon, where patients will have said they had a cartilage injury as a kid, they had a microfracture, and they really didn't get that much better. Now, it's probably because it's more of an OCD where the cartilage was flaking off and they had a bone injury underneath. So that's what this kid looked like. So he has this area which has some bone injury and he has this unstable cartilage flap area here. This is what it looked like when we opened it up. So obviously we didn't do a repeat microfracture. And essentially this is what happens with kids when you try to do a microfracture. The actual area didn't heal very well. And then you get this weird bony overgrowth because you're essentially just stimulating healing, which for kids is going to be easier for bone rather than cartilage. So then we end up doing a osteochondral autograft. So the limit is you can take usually 3 plugs, sometimes 4. We took 3 plugs, or 2 from one side, 1 from the other side. And this is an 8mm, 8mm, and 6mm plug. We didn't do anything over here because I worry in young people, if I go and rongeur off this extra little osteophyte, that it's just going to form a bigger osteophyte. And because this is core, he's doing amazing right now. Okay, so osteochondral autografts are not a new procedure. They were developed in Japan back in 1985, and it was really popularized by Dr. Hangodi, who was in Hungary, I think Hungary or Belgium, and he did over 1,000 patients in his initial experience. So basically, everybody who showed up to clinic, it was, you're going to get a mosaic plasty. Okay, the technical term for it is mosaic plasty, and osteochondral autograft transfer system, or OATS, is the trade name. Okay, so that's, if you're talking non-specifically, you should say you're going to do a mosaic plasty. Okay, the advantage of an OATS, however, since I was not good at this, is it's autologous tissue, and you're looking really for bone-to-bone healing in terms of return to play. You're bringing viable chondrocytes from one part of the body or one part of the knee and transferring it into the other. Sometimes we'll actually take the knee and put it in the capitellum or into the ankle. So you can say one part of the body. It's pretty good for larger defects, but it's not good for huge defects, obviously, because you end up with a donor site problem. There is a size limit. My max I'll do is 3 plugs. If you look at the original data, the initial pictures, you'll often see like these like mosaics of like 15 plugs in the knee. There's no place to take 15 plugs, and there's no, like, that's going to take 7 hours. At that point, you might as well do 1 allograft. Contouring issues, if you look at patients carefully, the contour is never perfect. And there's considerable donor site morbidity. So oftentimes I will tell patients, well, if this works well, it works fantastic, but we are borrowing from one part of your knee, and you may end up with some patellofemoral pain as well, which kind of sucks. Okay, so the technique, I usually will do a slightly left or right of midline incision, but if I'm doing a concomitant procedure, I'll do a midline incision, especially if I'm doing an osteotomy. You identify the defect, clear off all these edges, and then it's a relatively straightforward procedure. So you basically, the most important thing is to get this system lined up so it's perpendicular to the cartilage surface, which is sometimes a little bit hard to line up. I almost always will take from the trochlea. I don't like taking from the notch because I think that the shape and contour doesn't match up very well with any place else, whereas the trochlea matches up pretty darn well. So these are what your donor site areas look like. If you notice, you want to leave a bridge here. If you don't leave much of a bridge, 2 things happen. One is your bone underneath, after you get about 8 to 10 millimeters, kind of converge. So you end up with a hole in between. And then this bridge, you can actually get a stress fracture in. So I will always backfill these with allograft dowels. I had one patient that I didn't, and he developed a stress fracture right through there at about 4 months. We basically let him go back, and he developed this huge bone marrow edema pattern. I ended up having to put him on crutches. Also, if you don't backfill, I know from experience, it hurts. When you get these plugs, these are usually about 10 millimeters in depth. You can go as short as 6 or 7. Anything less, it's largely cartilage. You're not going to get much bone healing. And then essentially what you do is you take this plunger and push it out, rongeur out these edges so it's a little bit more conical, and then impact it into place. Once you impact it into place, and this is a nice example, it always looks good, but not perfect. But that's how your cartilage often is anyway with grade 1 or 2 cartilage loss. So this actually, I would say is, I would give myself a B+ on it, especially when you're looking at these larger lesions. You almost never get an A on how it looks. And I would tell you the last one I did that I gave myself an A+, one of these plugs, the cartilage sheared off and they now have an osteochondral allograft. So even if it looks perfect, weird things can still happen. Okay. All right. So Oates outcomes, this was his original like long-term follow-up procedure. So in 2008, he published almost 1,100 cases, and he put these in everywhere. So even I don't know how you do it, but he put 31 on the tibial condyle. Most of these were in the femoral condyle, and he was super aggressive. And you can see most of these patients came in and had something else as well. So a lot of them, about 30% had ACL reconstruction, about 15% had realignment osteotomy, and a bunch of them had meniscus repairs. Overall, the outcomes in these patients were pretty good. I think importantly, we talk about Oates as a outcomes procedure that works better than microfracture for the right patients. I do want to point out that this study, we don't really talk about it as much, but they did notice a decline of activity rating from 2 years to 7 years. So their Tegner score went up, but then it started coming back down. And I think that's important because we always say that for microfracture, but we don't always say that for Oates. You do kind of decrease your activities. Now, the complicating part is these patients are usually in their 20s. And when you go from 20s to 30s, you have a decrease in your activities at baseline. You get your first real job, you have your first real child, or you get a dog, and all of a sudden your activities decline. So you don't really have age match controls to look at this. Okay. Okay, we're okay on time. All right, so this is a more typical patient of mine. He's 48. His BMI is a little bit higher. 6 months of knee pain. He was run into by a forklift at Costco. He was not working there. He was behind the part that they tape off so you can't get in there, but he was going for a snack and the forklift backed into him. He said he had surgery 15 years ago. He's not really sure what type, and he comes in with this MRI. So for this patient, this is the original MRI we show, X-ray and MRI we showed. So his story, when I found out a little bit more about him, is he actually had a chondral dart system. So he had a OCD lesion that was provisionally fixed, probably did fine for quite a while. And then he eventually developed some reabsorption around the old biodegradable screws. So one of the problems with these old biodegradable screws is that once you reabsorb them, you will form a cyst. And if that cyst gets big enough, as you can see this one has, this cartilage is eventually going to get a little bit thicker. Okay, so when you look at this, well, that doesn't look that bad, right? So it's like, okay, well, cartilage looks okay. He's got some fissures, but he's older. He's a little bit heavier. When you look at it this way, you're like, okay, same thing. It doesn't actually look that bad. Maybe it doesn't look horrible. But then when you start playing with this lesion, you see that this whole thing is completely unstable. So this entire area, which is about 2.5 by 1.5 centimeters, is completely unstable. And if you can imagine walking on that cartilage is flapping back and forth. It's going to give you a huge effusion. And it's really not going to be comfortable at all. So I think
Dr.
if you're
Feeley, how did his tibia look?
amazing. Totally amazing. Absolutely no problem with his cartilage there. It actually did look pretty okay. And his meniscus looked okay. His ACL was okay. His main problem is he's really, really big, and he was too big to really tolerate crutches well. So we ended up putting him in a wheelchair for 6 weeks. But so this is a perfect indication where there's only, as far as I can tell, there's really only 1 or 2 solutions. One solution is going to be a joint replacement. But if you talk to the joint replacement people and say, well, I'm going to do a horrible candidate for a partial knee replacement. He's going to be 48, overweight, not very active. And then I've got bone loss, so I don't really have a great supporting structure on the femoral side. So he's at high risk for failure of a uni. I don't want to do a total in somebody who's 48 when 97% of the cartilage looks good. So even though he's not a perfect candidate for a cartilage procedure, I think this is the right option for somebody like this is an osteochondral allograft. If for no other reason, even if the cartilage fails, if he can heal the bone behind this, then at least he has a stable platform in the future for a partial or total knee replacement. Sort of makes sense? Okay, so what we do for these patients is we take 1, 2, or sometimes even 3 plugs. The nice thing with an osteochondral allograft is that we can solve a cartilage problem and a bone problem at the same time. The way we used to do these is we used to do like usually 16 to up to a 28 centimeter round circle. So it'd be 16 millimeters in depth and up to 28 millimeters, 16 millimeters in depth, 28 millimeters, not centimeters, that's huge, in circumference. And you could essentially replace the entire condyle. Most of the studies that you'll read about this come out of William Bugby's lab in San Diego. In fact, I think 97% of the good studies come out. He publishes about 5 a year, and they consistently show really good outcomes for the right patients. What we've done more and more for these patients is the plugs are getting smaller because we know that the success rate partially depends on your bone cells migrating in to try to get at least the sides to heal. So more surface area is good. If you have one huge graft, it doesn't tend to work as well as this Mickey Mouse kind of double ear phenomenon. Usually that is only if you look sideways. And if the contour works well, and we don't drill nearly as deep. So normally now it's about 6 to 8 millimeters. So it's not quite a shell graft, but it's not nearly as deep. For this one, because he's got that big hole, you need to at least get deep enough to get to healthy bone. So we did about 14 millimeters in depth for this. Okay. This has been around forever. Okay, this is not a new procedure. All the way back in 1999, Bugby published a 5-year follow-up with 85% good to excellent results. Not surprisingly, every decade you see a little bit of a decrease. But overall, I tell my patients, this is a procedure that's going to give you 10 to 15 years where you're going to feel pretty good for your knee. And I think it's a really, really well indicated procedure for the right patient. Bigger lesion with bone loss. Okay. All right. Questions so far?
Yeah, for
Yeah.
a patient who might have a large cartilage lesion like that, and if they have like a deficient ACL or something else you need to address, do you do those simultaneously or do you stage them?
Yeah, simultaneously.
Okay.
So it's a good question. The only things that I will stage really are an HTO or an HTO or DFO and a concomitant cartilage procedure. And even that's pretty rare. And usually the reason I will do that is because let's say you're medial meniscus deficient or you've got a medial femoral condyle lesion, you're ACL deficient, and your meniscus is mostly okay. And you have a malalignment in your late 40s. I will do an HTO first because the data suggests that if I flatten the slope, I really offload them 8 to 10 degrees. There's a 2 out of 3 chance I never need to do an ACL or a cartilage procedure, and they'll be just fine. So you can use the HTO to solve the other problems for the patient. That being said, with any malalignment, and especially in the patellofemoral joint, you should almost always be doing some sort of osteotomy. So, and we'll talk about that in a second. But most of the time when we talk about staging, we talk about it for MACI, which we'll get to now. But going and doing like just the ACL and leaving the cartilage isn't a great option. Having an unstable knee is a contraindication. Now, Charlie's thinking, well, what does insurance do with this? If I say I'm going to do a meniscus transplant, ACL, and MACI procedure, they're looking at a $60,000 surgical supply bill. And not surprisingly, most insurance companies will deny that, and you have to appeal it. And usually takes about 3 to 4 months of appeals before you can get it accepted. The last guy I did, the insurance company would either approve the transplant or the MACI, but not both. or not neither. So basically, I could either do the meniscus transplant or the cartilage procedure. And I kept telling them, well, there's no reason to do one without the other. And they're like, yeah, we know. That's why we're saying no. And it finally took I sent them about 30 articles, and they finally said yes. So if you're persistent, you can get it approved, but it is kind of a challenge. Okay.
Dr. Feeley, just to verify that all of these procedures are usually femoral sided or patellofemoral sided and not tibial sided, correct?
Yeah, we do not have a good option for the tibia. And you'll notice when you hear cartilage talks, we almost never talk about the tibia. For the most part, uncontained lesions in the tibia, so that are not underneath the meniscus, don't do very well. And microfracture does not work for them. And there's no other way to access them.
And in terms of the osteochondral allografts, are like, how do you exactly find out? Like, does someone call you when the patient dies, and then they have to know that, hey, your surgery is within 1 week?
Yeah. So what happens is, you will get essentially you will get a email now. It used to be a phone call from the rep saying, here is a donor. Here are this one looks like it may match pretty well with the patient that you have. That's honestly up to the rep. So you have to look carefully. Some of the reps will look for a perfect match. Others will look for something within the ballpark, meaning it's a human. So you have to check and make sure, one, it's human, two, that it's reasonable. And then what happens is it goes through a secondary screening process. And about 20% of the grafts drop out in that secondary screening. Either it comes up as cultures come back positive, the screen turns out that they actually had Hep C, something that you don't want to give the patient. But then essentially what happens once you say yes, you call the patient, they've got about a week to get that scheduled. Almost always patients say, come back. I've had patients who are away on trips and they come back for this. So, and I think with the exception of COVID, for the most part, it really doesn't become too much of a logistical issue. Okay, so we're going to talk about this patient, and we're going to stop in about 5 minutes. So we'll go relatively quickly. So this is a 32-year-old female, 3 years of increasing anterior pain, left greater than right. She's got a little bit of patella alta, and her TT to TG is 21. So I keep seeing Charlie. So Alex, I know you haven't done sports in a long time, but do you remember what a abnormal TT to TG is?
I'm trying to think of an abnormal. I want to say it's above 12 millimeters.
12. Okay. Hunter, do you remember what it is? I'm purposely picking on people who haven't done sports so far.
So I think like 15 to 20 is kind of borderline, and then greater than 20 is generally considered abnormal.
Okay. Abi, I know it's been a while. What do you remember?
I remember greater than 20 is abnormal.
Okay. All right. So the reason I ask you guys and ask you fairly randomly is it really depends on which study you read and what you decide is abnormal. And honestly, where on the tibial tubercle you measure. The trochlea is pretty straightforward. I picked the midpoint. We're technically supposed to pick the midpoint of the tibial tubercle, but when you watch in conferences or watch an indications conference, if I want to do an osteotomy, I will move that all the way over here. I'll be like, look at the tibial tubercles here. Tibial tubercle, that's a 27. Depending on the study, I think people who are more aggressive will say 12 is absolutely normal. 15 to 20 is a gray area, but most people that treat a lot of patellofemoral disease are using 15 to 16, and over 20 is absolutely abnormal. And then a Caton Duchamp's greater than 1.2, so measuring from here to here, here to here, and then the ratio of that over this. So anything above 1.2 suggests patella alta. And then her cartilage injury kind of extends to the mid portion of the patella and all the way over, and we don't get a good trochlear view, but the trochlear cartilage actually looks pretty okay. So this is somebody who has some cartilage injury, some patella alta, and a somewhat elevated TT to TG, which I think, honestly, I kind of over measured. Okay, so when I think about what I want to do for these patients with patellofemoral disease, I want to think about the following. Can I fix it with alignment alone? And certainly doing just an osteotomy is a lower morbidity procedure. It's a much smaller surgeries. And there are some patients where you can do just a tibial tubercle osteotomy. Do you need to add stability? So if we're talking about instability or trochlear dysplasia, which is kind of a separate talk, do you need to do an MPFL imbrication or reconstruction? And do I need to add cartilage restoration? And if so, which one? For the most part, and because we're running out of time, we're going to talk about MACI, or matrix autologous chondrocyte implantation. So there's not a ton of data on just patellofemoral disease, but I think most of the data in the patellofemoral compartments supports MACI as probably the dominant treatment strategy. So this was a really nice study that came out in Cartilage a couple years ago. It's a relatively small group of patients, so only 17 patients total. And they compared microfracture and MACI. And you think about it, microfracture is really nice to do. It's really quick. Patients probably do okay. But especially in the patella, it's actually really challenging. Their subchondral bone is ridiculously hard. So it's very hard to not scratch up the entire patella trying to do it. In the trochlea, it's pretty easy to do. There's some data that it works okay, but even that data is not that great. But if you look at these patients at the end of follow-up, so they had about 4-year, I think 4.5-year average follow-up, relatively middle-aged patients. In all these patient outcome scores, the MACI worked better. So a lysome score, Kujala, which is for patellofemoral pain, IKDC, which is a kind of global cartilage and knee outcome score, they all did better with the MACI. So I think MACI in general works better for a patellofemoral disease. I always think it's nice to know which authors you should just search and get the most comprehensive data. And it's a good way to weed out PubMed. So if you look up this group, they've done a ton of MACI studies. So Jay Ebert and Gregory Janes are out of Australia, and they essentially have a really nice cartilage registry. So if you're like a 3rd year finishing up and you're thinking, gosh, I'd really like to go to Australia and work with a group, is this a good group to work with? Yeah, they're fantastic. They publish really interesting studies and they have really good follow-up, Marcus. So if you look at this study, they looked at what we traditionally think of as a good cartilage patient, like undergoing a femoral MACI or a patellofemoral MACI. And what they found was overall the outcomes are pretty much the same. At 24 months, most were satisfied with knee pain. About 2/3 to 3/4 were able to return to sport, and most of them were satisfied overall. So overall satisfaction, oftentimes they haven't gone back, but they're still satisfied. The fill was pretty good in both, and actually a little bit better, and did reach statistical significance in the patellofemoral patients. So even though the loads are different, MACI works just as well as the patellofemoral or in the tibial-femoral compartment. I think the other advantage of MACI, I initially, when Drew came back, this is kind of the standard thing that they do at Rush, that almost everybody with a cartilage injury gets a staging arthroscopy, a MACI biopsy, and then kind of a let's see how you do. And at first I thought, well, this is relatively ridiculous. We're telling patients to have 2 surgeries instead of 1. You should be able to pre-plan. But the more have experience with both doing MACI and seeing how patients do with that first cartilage procedure, I actually think it's a really good idea for a couple of reasons. First of all, I think the MRI tends to undercall what it looks like. Oftentimes, by the time you start flaking away the good healthy rim, those ones that you were thinking this will be a good microfracture, by the time you get to a healthy, stable cartilage rim, it's pretty big. Second, some patients just get better. They feel better. The cartilage that you send off is good for 5 years. So there's no rush to convince patients they need that second surgery. Some of them will do well with just the debridement. I have a couple patients I've done the debridement, especially for a loose body removal, and they're absolutely fine. No swelling, don't really want surgery. And if they are disasters after a really, really tiny procedure, I need to counsel them effectively. So I have a couple patients that I have told you're going to need a pain psychologist or a sports psychologist after the real surgery if you want to proceed with it. And they're usually pretty reasonable. They know they were miserable after a tiny procedure and they're worried about the big procedure. So I think this staging procedure, you don't want to be staging everything, but for something complicated like cartilage, it gives you a little bit more time to think. It also importantly allows you to look at the other compartments really carefully and make sure you're not missing anything. Okay. For me, I'm pretty aggressive about when I add a tibial tubercle osteotomy. My magic numbers are a TTTG of greater than 15 or any patella alta, because I think for the patellofemoral compartment, you really want to be adding in a tibial tubercle osteotomy pretty aggressively. This was a nice paper that just came out this last week by Seth Sherman. And this is a really, like, avoid the 1.2 years, but I think this is a really nice algorithm where it shows a TT to TG and isolated cartilage loss just on the outside. You can do just a tibial tubercle osteotomy. But as soon as you move into that central area with a bigger TT to TG, you should probably do a osteotomy where you're a little bit steeper and to really offload that central portion, and you're going to do cartilage restoration as well. Okay, so that's just a prettier picture of that. That's offloading for the distal lateral defects. I'm actually going to stop there so you guys have a chance to ask questions and take a 30-second break or 2-minute break. So any questions? Oh,
Is it
Carly,
more?
is it
more
more
expensive for the patient?
No, it depends on their out-of-pocket max. So yes, sometimes it is, but compared to what? So most people have an out-of-pocket max of $2,000 to $5,000, rarely 10,000. So yeah, if 10,000, you may not reach it with that first surgery, but for most other things, you're going to reach it with that first surgery. And certainly at 2,000, as soon as you have one procedure or 5 to 10 physical therapy visits, you've already reached it for that year. The tough thing is, if I'm a savvy insurance company, I only approve the biopsy at the second half of the year to hope I get the new out-of-pocket max for the new year, which is shitty, but I have had insurance companies do that.
Dr. Feeley, for patients with osteochondral defects, have you ever had one so large where you actually have to bone graft in there as well as put your plugs in, or do you typically get to that?
No, so if I have to bone graft, I'm going to do it with the plug. So I'm not going to I'm not going to put anything other than the plug in. Some of my friends will do, like, let's say they have a bigger defect, they'll do bone marrow aspirate underneath the plug and then put the plug in, which seems borderline moronic because you're drilling into the bone marrow, but not all my friends are smart. So it is what it is. All right, I'm going to let you guys go.